Dr. Rajan is there? Change in beta cell function, GLP-1 and calcitonin levels 2 weeks after bariatric surgery from JIPMAR.
Good morning to everyone, my respected judges, teachers and my colleagues. Today I will present our study titled Change in beta cell function, glucagon-like peptide 1 and calcitonin level 2 weeks after bariatric surgery, an exploratory study. So today in the era of epidemic of diabeticity, bariatric surgery is an effective mode of treatment. Bariatric surgery causes profound improvement in metabolic parameters, particularly in glucose homeostasis. However, Indian studies exploring the mechanism behind this glycemic improvement are sparse. Another issue is that use of GLP analog have been associated with medullary carcinoma of thyroid and rise in calcitonin level, but mainly in the rodent studies. Bariatric surgery is a state of endogenous GLP-1 excess, thus can lead to change in calcitonin level. Serum calcitonin level following bariatric surgery has not been studied before. So the objective of our studies are to measure the change in beta cell function, GLP-1 and calcitonin level before and 2 weeks after bariatric surgery, and also to look for correlation between changes of GLP-1 and calcitonin levels. Our study is a prospective clinical study with a before and after study design done in Department of Endocrinology and Surgical Gastroenterology, JIPMAR, from January 2016 to November 2017 after getting ethical clearance. All the patients with the age of 18 to 65 years who had underwent either laparoscopic sleeve gastrectomy or Roux-en-Y gastric bypass were included in the study, where a patient with CKD, CLD or personal or family history of medullary carcinoma of thyroid, history of use of GLP-1 analog or pregnant mother were excluded from the study. All the patients were, after getting written informed consent, following tests were done before and 2 weeks after the surgery. Oral glucose tolerance test was done and both fasting and post-OGTT glucose, insulin and GLP-1 were measured. Calcitonin level measured only during fasting state. Insulin and calcitonin were measured by chemiluminescence and total GLP-1 were measured by ELISA. Following indices of HOMA2-IR, which is a suggestive of hepatic insulin resistant, Matsuda, insulin secretion and insulin sensitivity index 2 and area under curve for glucose, insulin and GLP-1 were also calculated. Statistical analysis were done as per standard guideline. Coming to the result, a total 36 patients were recruited in the study, of which 28 patients finally completed the study, of which 17 underwent laparoscopic sleeve gastrectomy and 11 patients Roux-en-Y gastric bypass. In the baseline cohort of our patient, 18 patients were female, 53% of patient hypertension and 46% diabetes and 85% has dyslipidemia. Following 2 weeks after the surgery, there was mean decrease in the body weight of 8.8% and percentage of excess weight loss was 17.82%. There is 50% decrease in the number of patients requiring anti-diabetic therapy at 2 weeks of follow-up, and mean insulin requirement decreased from 14 to 12 units per day. Coming to the OGTT values, that there is significant decrease in the fasting and 90 and 120 minutes of plasma glucose following 2 weeks of surgery, though the area under curve for plasma glucose did not change significantly. There is significant decrease in the insulin level at the fasting and 120 minutes, and there is significant increase in insulin level at the 30 minutes post-surgery, and there is no significant change in the area under curve in serum insulin, but there is change in the insulin secretory pattern. We can see there is an earlier rise and in the higher rise of serum insulin followed by a rapid decline following post-surgery. And the marker of beta cell function and insulin resistant index, HOMA2-IR, has been decreased significantly following surgery, though Matsuda index, which is a marker of total body insulin resistance, did not change significantly, but it showed a trend of improvement. ISSI2, which is a marker of beta cell function, has been improved significantly post-surgery. If you see the pre and post-surgery GLP-1 level, though there is no change in the fasting level, but there is significant increase in all the post-OGTT values of GLP-1 along with the area under curve of GLP-1. If you compare all the three area under curve, we can see that there is restoration of the incretin response following bariatric surgery, leading to early rise of GLP-1 that lead to an earlier and steeper rise of insulin 2 followed by rapid decline, which might explain that there is decrease in the better glucose control following bariatric surgery. We have also measured the serum calcitonin, and we did not find any significant change between serum calcitonin pre and post surgery, and there was no correlation between change in plasma GLP-1 and serum calcitonin. Just to summarize, there are 28 patients underwent bariatric surgery in this study, of which 17 patients of laparoscopic sleeve gastrectomy and 11 patients of RIGB. After 2 weeks following surgery, there is 8.8% body weight loss. There is decrease in the requirement of anti-diabetic drugs. There is decrease in the fasting glucose, insulin, and HOMA2IR, and improvement in the beta cell function as by ISI-2 index. There is also increase in the postprandial GLP-1 and area under curve following bariatric surgery. There is no significant change in peripheral insulin sensitivity, and we did not find any significant change in serum calcitonin level, and there was no correlation with the change with the GLP-1 level. The strength of our study is that both the indices of beta cell function and incretin hormone response were assessed to characterize the mechanism of glycemic improvement following post-bariatric surgery, mainly in the early period where significant weight loss has not occurred yet. And we also assessed calcitonin concentration after bariatric surgery, which was not reported before in the literature. The limitation of the study is that of the heterogeneity of the cohort, we included both RYGB and LSG patient along with diabetic and non-diabetic patient, and non-inclusion of the non-surgical control group like acute calorie restriction, and we use OGTT for assessment of beta cell function while CLAMP studies are gold standard. Thank you.
Did you find any difference between the two groups, LYGB and Roux-en-Y bypass and sleeve gastrectomy group? I don't think you presented any such difference, no?
No, we have done this. We have not presented yet, but we in our cohort of the patient is predominated by laparoscopic sleeve gastrectomy, and in the baseline cohort, the more diabetic patients were in the Roux-en-Y group because that diabetic patient, the Roux-en-Y was preferred.
Sorry to interrupt. How many were diabetic patients in your study? 13
patients were diabetic, sir. Out of the 13 patients.
So how many were on insulin therapy?
Before surgery, 5 patients were on insulin therapy.
And you measured insulin after surgery in all these patients who were on insulin therapy also?
Sir, as per the protocol, before doing the OGTT, we have stopped all the oral diabetic agents 72 hours before. And both that NPH and long-acting insulin was stopped before the last night, and glucose, regular insulin on the day of the OGTT morning. And we have measured both pre and post.
No, post-operatively those patients would have been requiring insulin, isn't it? Some patients.
Only one patient was requiring insulin.
All other patients, insulin was totally stopped in the post-operative, even in diabetic patients.
Because of the control of the diabetes, it was not required, sir. Only one patient required insulin.
What is the scientific logic of doing calcitonin?
Sir, the logic of doing calcitonin is that use of GLP-1 agonist in rodent studies, but not in monkey or human studies, has shown an increase in the.
Then we should do GLP-1 therapy patients. We should check calcitonin. That's more logical. That's a supraphysiological increase, no? If my guess is right, the Roux-en-Y bypass people will have more GLP-1 increase than the sleeve gastrectomy, no?
Yes, sir, because of both foregut and hindgut.
That would have been more interesting to see that.
For the initial rise in the insulin level followed by a drop, we have shown the graph.
Yes, sir, initial rise in insulin level may be because of the restoration of the GLP-1 rise following bariatric surgery. That because of this incrementing effect, there is initial rise of the insulin at the 30 minutes. As there is rise of the insulin of the 30 minutes, so there is, after that there is decrease of the glucose at the 60 and 90 minutes. So because there is fall in glucose level following rise at 30 minute insulin, that can lead to the further decrease in the insulin level at 120 minutes. That is our probable explanation of this.
So, okay.